will be moderating the next panel, which is our bread and butter, near and dear to my heart, navigating fertility with endometriosis. And I am honored to welcome to the stage Dr. Levine and Dr. Luke. Briefly, Dr. Brian Levine is the founding partner and practice director of CCRM Fertility of New York. He did his OBGYN training at Columbia University Medical Center and did his reproductive endocrinology and infertility training at Cornell. He has many years of experience in IVF treatment, IUI treatment, PCOS treatment, gestational surrogacy, LGBTQ reproduction, and many other areas. He's board certified in both reproductive endocrinology and infertility and obstetrics and gynecology. Dr. Levine leads the industry in normalizing open dialogue about infertility and educates prospective parents on a national level. Welcome, Dr. Levine.
Thank you.
And Dr. Janelle Luke is a board-certified OBGYN and reproductive endocrinologist and the medical director at Generation Next Fertility. Dr. Luke did her OBGYN training at Brigham and Women's Hospital in Boston, and she did her REI training at Yale University. Dr. Luke specializes in personalized fertility treatments, addressing complex cases such as diminished ovarian reserve, unexplained infertility, and recurrent pregnancy loss. Dr. Luke's expertise is widely recognized in numerous published research articles and presentations delivered both nationally and internationally, including in China and Hong Kong. Please join me in welcoming Dr. Luke and Dr. Levine. Yeah.
I had to hide my coffee. I mean, we're on like a lot of cameras and videos here, so.
Well, hello and good almost afternoon, still the morning. So there's a lot to talk about here. And just to break the ice, and we're all dying to know what you, both experts in the field, have to say about endometriosis and fertility. So what do we currently know about how endometriosis impacts ovarian reserve and fertility?
You want to go first?
You get started.
Well, I cannot believe this. Oh my God, endometriosis generates such interest. On Sunday, I thought today would be a few people, and Dr. Sheshin's like, no, it's a full house. Look at up there, down here, and I don't know if you guys know, this is a Lenox Hill Grand Rounds. When we do grand, this is the first time I see every chair is being filled. So this is amazing, even more than a Grand Rounds. So I'm so excited to see all of you to talk about endometriosis. And I thank you so much, Dr. Sheshkin, for inviting me. And I don't know if some of you came to this event. I come to this event every year. It is a very amazing that this disease is being talked about more and more every year, and gain the really empowerment that we want for every woman, and not that, oh, you just have pain, it's okay. To answer the question, how do we currently know about, I'm so sorry, Sheshin, I may have digressed, so.
Okay. So what do we currently know about how endometriosis impacts ovarian reserve and fertility?
Yeah, I think that endometriosis is about 30 to 50% of this well study with people who are impacted with endometriosis can have infertility. And also on the other way around, 30 to 50% of patients with infertility may have endometriosis. So it is well studied, and lots of data have been going into this. I want to be clear, ovarian reserve, however, may not always equals to you have endometriosis, you have decreased ovarian reserve. And I just want, endometriosis is one of my passions. The reason is because I am a endometriosis patient. I was in medical school in lots of pain. They diagnosed a dermoid on my ovarian cyst, on my ovary, and I didn't know. I was so scared. And when you're in medical school and you think you have cancer, that's all you think about. When we study all kinds of cancer, you see all kinds of things like, I have cancer. That's what I thought. I told my mom, oh my God, I don't know what to do. I'm in debt with tuition. I have cancer. No, dermoid cyst is a benign ovarian cyst. And so then when they went into my belly, then you don't want any cysts. Even the doctor says benign. I don't care. I saw the rare case, benign become cancer. I want to get it out. So they did surgery, and I was at Brigham. So one of my mentors did the surgery on me, and they discovered endometriosis. And to discuss why I brought that story, because obviously I was a medical student. I was not ready to, I don't know, ovarian I do look a little bit, it was about 20 years ago. So ovarian freezing was not really readily available, but the first thing I asked is, what about my ovarian reserve? And obviously my doctor, Jan Schpolsky, and Dr. Hornstein was like, no, it doesn't really affect your ovarian reserve, and it didn't really quite affect my ovarian reserve at that moment, and those are really basic data there. But because you're doing endometriosis surgery, so they're removing the cyst and some endometrioma around the ovary, that sometimes can impact your ovarian reserve, so after the surgery. And in terms of infertility, yes, so the first thing I woke up, my mentor is like, Janelle, plan of having a baby earlier. I was like, okay, sure. I mean, you're at medical school and residency, you know, plan. So I was in my late 20s. And so, yes, it does affect fertility, and majority of the time I always tell my patients, you know, thinking about age versus endometriosis is not just endometriosis can affect fertility, but age with endometriosis can sometimes also affect fertility. So I'm sorry, it's a why question, so I'm going to give to Dr. Levine to see if there's any insight in that.
So I'll be short because I know that we want to get through a bunch of questions.
Yeah, sorry.
Fun fact for the group, Janelle and I went to college together, so we were actually the same year in college. So this morning I saw 65 patients in my office. Of the 65 patients that we saw in our office, I would estimate 1/3 to 1/2 probably have some diagnosis of endometriosis or something like that. And the reason I say something like that is that unfortunately in the infertility population, endometriosis is rarely diagnosed but often suspected. People walk around suffering with unexplained infertility, which I call the laziest diagnosis known to man, right? When people are, there's no other field in healthcare where it's acceptable to be, undescribed or unexplained, right? No one goes to the oncologist and says, just give me chemo because I have unexplained cancer. No, you have a type of cancer that they treat. What ends up in infertility, a lot of patients come through with either pelvic pain or infertility, or for example, they have a cyst on their ovary, and so we see it more often than not. To answer the question about ovarian reserve, so the who, the what, the where, the why, the how, all of those things affect your ovarian reserve. And what I say is that if you go to a surgeon who's going to do excisional surgery versus a surgeon who's going to do destructive surgery, your ovarian reserve is going to be different. So where you go and who does the surgery and when you do the surgery and why you do the surgery is going to greatly impact your ovarian reserve.
Thank you. And in terms of the population that comes to you for elective fertility preservation, when should those with endometriosis start considering egg freezing?
Because we just talk about the surgery, when and how can definitely affect ovarian reserve. So if you are currently not considering to get pregnant, we do advise patients to think about, we do offers and options for egg freezing, because egg freezing preservation also correlated with your family planning. If the plan is to have a baby after the surgery, I usually would ask why what's the purpose of egg freezing, and lots of questioning for the patient's rationale and logic. Because after you do the surgery, there is a great improvement for fertility. And so some patient would just try and get pregnant and have sex and intercourse right after the surgery, and I've seen lots of success. And so egg freezing and preservation will be, well, if you intend to have a second child or you want to freeze it for a third child. So that's one option and one timing. And second is patients who are single, who are doing endometriosis surgery. We do see lots of patients now doing egg freezing prior of them doing surgery to reserve, to help with their ovarian reserve.
So I'll take the other side of it. No pun intended. But I think egg freezing is the coolest technology that we have. It is the only tool that we have to protect and preserve someone's fertility, full stop. It is unfair, it is unfortunate that it requires 2 weeks of shots and it requires a retrieval, but it is the only thing that we can offer a patient to help her stop the clock, which is the clock against aging. On the flip side, the clock against destruction. We know that endometriosis is an incredibly progressive, destructive disease that has the ability to really destroy someone's fertility. In fact, I would argue that some patients will have better egg quality after having excisional surgery and actually going through a surgical procedure than freezing eggs before. Now, New York State is one of the coolest places on earth, not because it's 9 degrees today, but it is one of the most amazing places because in 2021, Governor Cuomo, who I guess might be Mayor Cuomo, whatever, made this really cool thing in the budget of New York State, which actually said that any employer that has 100 employees or more needs to have a fertility benefit. So there's lots of companies out there today, from Google and Facebook and Uber and Lyft and McKinsey and Goldwell and Wachtell Lipton, and like all these great companies who have fertility benefits. So what we're seeing is that patients have the ability to freeze their eggs on their company's dime, and so they freeze their eggs first. Then they go through a excisional surgery. Then they come back to us again, a second time potentially, or a third time to freeze their eggs. And the reason is that A, we see that egg quality is improved post-surgery, and B, people want to know that they get as many eggs as possible before the surgery in the event that the surgery is really intense and they lose ovarian function or ovarian tissue.
Thank you. What are the success rates for egg freezing for patients who have endometriosis versus those who don't? Do you see a difference for those who come back to use them?
Endometriosis itself does decrease, possibly decrease the egg quality. As a result, the fertility is affected sometimes because of endometriosis. But one more time, what we have done, and certain papers have discovered this, is that if you're freezing which is to Dr. Levine's point, if you are younger and you're now trying to preserve, because age is one of the biggest factor affect egg quality. So the younger you are, when you're able to freeze your eggs, that factor of endometriosis may not affect the ultimate fertility potential for your frozen eggs. And that is what we have seen.
So eggs are just half of the recipe, right? To bake the cake of a baby, it's all about the ingredients and the oven. So the ingredients are the egg and the sperm, and then the oven is, of course, the uterus. So in endometriosis patients, I always refer to everyone to think about the steps of the process. You can have the most amazing recipe and the most amazing kitchen, but if the ingredients aren't good, you're not going to be able to bake the cake the way that you see Martha Stewart do. So the example I'll give people is if you want to freeze your eggs ahead of time before having endometriosis treatment, go right ahead. But if you think about egg freezing as a marathon and not a sprint, and you prepare yourself by maybe following the appropriate endo diet, by maybe having surgery before, or maybe preparing your body to have the best egg quality, you can get the best eggs out. But that's only half the equation. The other part is actually putting back the embryo. And what I would say is that the endometriosis patient unfairly has multiple challenges throughout their reproductive journey. They have challenges sometimes in getting pregnant on their own because of the pain of intercourse. They have trouble sometimes getting pregnant because the egg quality could be impacted by endometriosis. They can have terrible problems getting pregnant with an embryo just implanting or sticking or persisting or miscarrying early. So the continuum of the reproductive journey can be greatly impacted by endo at almost every step of the way. So to answer the question, please freeze your eggs. As soon as you think about doing it, you should be doing it. Make sure you go into it the right way, but also remember that's not the only step that you're going to need to do potentially to be able to get pregnant with a successful pregnancy.
Thank you. You brought up a lot of important points about what should be kept in mind for somebody with endometriosis and preserving their fertility. Are there any other misconceptions or common myths about egg freezing or fertility preservation for those with endometriosis?
I actually want to this is actually a great point because everyone, and I think this is actually to Dr. Levine's point about, because I know we keep on talking about egg freezing and endometriosis, which is interesting.
Yes.
And it is really half of the recipe. And so the myth is that I frozen my eggs, it will work, or it is not true because the process and journey also involve how does it affect the uterus in the later time when you are putting in the embryo. So, for example, if a patient froze her eggs at 25 And hopefully, and this is where I always tell patient, and I know I sound like them, I don't know, their family or mommy, I was like, oh, try to get pregnant, if you're with your partner, I know you froze your eggs, please plan early, because again, age is such a big factor. I always promote my patient, please go and, try to get pregnant. And after they get pregnant, now they're coming back for the second child. Now this is where the difficulty, because now the endometriosis may have grown back. She's now in more pain. And they thought they were all set, but I was like, wait, your endometriosis did come back. Now we may need to work on the receptivity of this uterus to your embryo and your current state. And they're suffering. They don't want another surgery sometimes. They don't want to revisit because it's painful to think about that procedure. But this is where a great surgeon, mediocre surgeon, and you will see that in the country. And some of you who are possibly Dr. Sheshkin's patient, may have gone to many surgeons and keep on doing surgery once a year even. I've seen it. I've seen patients who've done 5 surgeries, and the 6th surgeon, or even when I refer to Dr. Sheshkin, they would say, oh my God, the endometriosis is all there, it's still there. And they just did a surgery a year ago. So that can be because of the disease, that can be the surgeon, but because the disease is a long-term inflammatory disease, it can affect the implantation of the embryo. So the myth that egg freezing may just fix everything is not true. Second myth is egg freezing. I think this is not a myth, but it is a process that I always tell patients. If you have severe menstrual pain, sometimes egg freezing can be a little bit more painful as in the recovery. So we have seen a couple of patients where they have severe pelvic, whatever, stage 1 versus stage 4 endometriosis. We do see the pain that they have. So I'm more catered to their pain after retrieval and to understand more pain management. I don't usually give oxycodone or any for the recovery, just Tylenol or Motrin, but certain patients I do advise them, hey, you may have more pain. And the more precise sometimes with also post-operative care for egg freezing patient with endometriosis. Sometimes I continue the birth control pill right after Dr. Sheshkin and I did a couple of cases recently with patients with severe endometriosis. So we had to give birth control pill right away after the egg retrieval so they don't get their painful period. So there are lots of things that we have to deal with when people are doing egg freezing. And I think that's more the second myth is it not a myth, but possibly a fact. Sometimes with egg freezing and for patients with dealing with chronic pelvic pain, they may deal with a tougher recovery.
So, fun fact for the audience. Endometriosis is the 3rd most common reason that people go through IVF worldwide. Full stop. Number 1, reason, advanced maternal age. Number 2, male factor infertility. Number 3, endometriosis. So why are so many people going through IVF who have endometriosis? And the answer is that because it's this progressive disease that can actually make the environment or the milieu be inflammatory, as Janelle was just hinting at, for suboptimal implantation, we know that it's a tough disease to treat. So a lot of people are going through treatment. But what I always advise patients is that sometimes you meet the highly educated endometriosis patient, right? Because these are chronic health conditions. So people with chronic health conditions tend to be very well educated. They tend to have gone down the rabbit holes of Reddit and Google and YouTube and TikTok and whatever else, but they're full of knowledge. And the question that we get often is, whoa, whoa, whoa. If endometriosis is an estrogen receptive disease, right? So estrogen makes it worse potentially. Isn't making my estrogen go up during egg freezing going to just add more fuel to the fire? Isn't this going to make it all worse? And the answer is maybe. But if you go to the right doctor who has the right protocol, who understands the severity of your disease, you can actually treat that disease in an appropriate way to make sure that we're keeping the estrogen levels low. For example, using something like letrozole. We can actually use something called a Lupron trigger, where we can actually try to limit the amount of time that you're going to have propagation of the estrogen within your body to help reduce this overall. We can give you an antagonist after retrieval to help drop your estrogen levels back down. As Janelle hinted, we can give you a birth control pill post your egg freezing to let your estrogen levels go down all the way. So the myth is that egg freezing might seem like a good idea, but it ain't right for me because it's going to make my disease worse. And the answer is, it might make your disease worse with the wrong provider, with the wrong protocol. But there is a way to go about this to help you protect and preserve your fertility.
Thank you. All very good points. And I was just going to ask, do you have any special considerations when doing a cycle, whether it's egg freezing or IVF for somebody with endometriosis? But the answer is a lot of that. Let's go a little bit back to the severity of endometriosis. How does the severity of endometriosis influence fertility outcomes, and what factors should patients keep in mind when planning for their future fertility, or if they're actively seeking conception?
It's interesting because we just talked about the top 3 that causes infertility. And endometriosis, when patient coming into with infertility, because endometriosis, the gold standard of diagnosis this disease is actually surgery. So, and patients do have commonly, and about 89% of us have dysmenorrhea, which is pain during periods. And then there are 2 other symptoms, which is pain during sex and pain during having a bowel movement. And those are the 3 top in our medical school or residency we memorize. Okay. But we also have a patient who doesn't have any of that. I have lots of patients with no pain, and we discover she has endometriosis later on. So the diagnosis of endometriosis is tricky. So there's, it is and I have seen, we talk about this with Dr. Sheshkins, and people have fulminant endometriosis and they only have little pain during period. Like you can see in the belly, it's like, what? They have endometriosis everywhere, but there's only little pain. So why I'm saying all this, because the presentation is so vast that you don't even, and then so now, if patient have no pain coming to my office and say, I have infertility, me and my husband have been trying for a year, and my tubes are fine, uterus is great, everything is great, and you cannot see sometimes endometriosis on ultrasound or MRI. So now, what do? Go to surgery? Go open your belly, see if there's endometriosis, then we treat your fertility. We don't, because patients don't have pain. You don't want them to have more surgical intervention that's unnecessary. So as we try to take care of these patients, usually IVF, and that's why IVF becomes so frequently being used, but without knowing really what we call, which is, I know, there's one diagnosis in IVF, it's called unexplained fertility. I know, it sounds horrible, because what you're coming for me for explanation, I'm telling you is unexplained. So yes, because if I didn't do surgery, I have no verification that you have endometriosis, you belong to a group of diagnoses called unexplained. It can be equality, it can be things that's molecular that cannot be diagnosed on blood work, on ultrasound. So for those patients, if you do have endometriosis, sometimes, and most of the time, IVF does help with increased fertility, and I treat it. And you may never know you have endometriosis, because endometriosis can be asymptomatic. But then for patients who has pain presenting and telling me, Dr. Luke, I've been having extreme pain, or the other reasoning that makes her very uncomfortable during her menstrual cycle, we then talk a little bit more endometriosis. I do love to talk about, hey, do you want to do surgery? What are your insurance options? Because if IVF can solve half the problem, it is more minimal invasive. It is much easier than a big surgery laparoscopy, so most patients will go towards IVF first to try to get pregnant. But if pain becomes a primary reason why, and infertility, and they come to us, then we usually will talk about the options, especially don't have insurance for IVF. Some of the audience was asking about, oh my God, what about finance? I was like, yes, I'm very sensitive to that. To me, it's part of the service for the whole fertility. It's very expensive. And so if patient does not have IVF coverage, I would talk more about what's your health inside your belly? Can we surgically remove some endometriosis and then improve time intercourse success? And it does. It increases about, I think it's about 10 to 13%. There are many different studies out there. So the percentage improvement is also variable, because how you stage endometriosis also can be variable. So, but it does improve. So in terms of fertility, if pain is not the instigator, and if then IVF does help with lots of patients with endometriosis. But if IVF also doesn't work for those patients who is asymptomatic, then surgery becomes another option before we do more cycles, especially back to Dr. Levine's point, embryo transfer. Because now we have other issues. We got your embryo, it's euploid, gorgeous, we can't implant. Why? So then many data in the last couple of years came out saying that endometriosis may affect the implantation of the embryo. So I hope I answered the point.
We're already going a
Sorry.
little over, but there are still a couple more points I want to get to. 2 more questions for me.
Yeah, okay.
I want to bring the table to thinking a little bit about endometriomas. What do you think of when you see an endometrioma? Who are you going to recommend has surgery right away?
Great. So it's been said that to have a kid, it takes a village. I would argue that to get pregnant, it takes a team. And so when you see an endometrioma that's there, that to me is the kickoff that we're going to have a multidisciplinary approach to helping this patient achieve their goal. So, right, I'm a fertility doctor. Yes, I'm a board certified OBGYN, and yes, I am trained to do surgery, but I'm not the guy who does endometriosis surgery every day. Right, I'm the guy who does IVF every day. Right, I did 6 cycles this morning, or 6 retrievals this morning. So you want me to be part of your team for doing your infertility, but then you want to know that I have kind of the humility to phone a friend. So I will call someone like Dr. Sechkin, or I will call someone else to say, let's make a multidisciplinary plan for this patient. And an endometrioma to me is the smoke that's there that says that there's a fire to be found. So sometimes when you see one on ultrasound, you then do an MRI. And sometimes when you get back that MRI, you're just completely aghast at the results. Thickening of the uterosacral ligaments, scar tissue throughout the belly, implants throughout the belly. Well, that's a no-brainer. That's a surgical patient. But sometimes when you have the patient who has an endometrioma that's there, that endometrioma might actually preclude you from safely retrieving eggs. Because what people don't realize is that an egg retrieval has to happen transvaginally. And so there's only really one direction that we get to go get that egg. And if those eggs are behind an endometrioma, the risk of a patient having an infection post-retrieval is through the roof. Right, back in the day in the 60s and 70s in medical laboratories, when they were growing bacteria, they used to grow it on something called blood agar. Blood is a really good medium for growing bacteria. Well, guess what? The reason that endometriomas are called chocolate cysts is because it's degraded blood inside of them. So why would you want to potentially introduce bacteria into something that can now get infected? And for those of us who have been practicing medicine long enough, we've all seen it happen, where the patient gets really sick post-retrieval. So when I see an endometrioma, it depends if I can safely access eggs around it or get to it. If I can't, then we have the multidisciplinary conversation right then. Or when it comes to post-retrieval and we're reviewing the IVF results, we talk about the plan for transfer. And sometimes we say, look, I would much rather you have surgery not pregnant than pregnant, because a ruptured endometrioma in pregnancy could become a true surgical emergency. So it's all about helping a patient understand the risks, benefits, alternatives of either going for surgery, not going for surgery, addressing it, or not. But another myth just to clear up, medical management will get rid of an endometrioma. I would love to find the drug that does it. And if anyone knows it, raise their hand, because I'm going to invest in your company like right now. There's no medical therapy that's going to remove an endometrioma. And in fact, most of them will progress and grow. So when I see one, it tends to be my little kind of flag to say, do you know what, we're going to talk about surgery down the road, maybe not yet, but you may need to go down that way.
Thank you. And my last question, what is one new treatment or methodology that you think could be helpful to endometriosis patients in their journey?
Can we each answer this one? Okay, fine.
Either.
No, go ahead.
Okay, so so here's the crazy thing. So I've been doing this now for 13 years. And when I started training, everyone gave Depo-Lupron. Raise your hands if you know what Depo-Lupron is. Of course. But most people who are not endo patients, who are not well educated about it, think this is the menopause drug. This is the drug that's going to put me in an irreversible menopause and make life miserable. I'm going to be like my angry mother was when she was 50-something years old, and I'm going to be going through these terrible symptoms. Then we had to deal with the symptoms, because we would give people Depo-Lupron, and then we'd have to worry about add-back therapy and to make them feel better because they just were miserable. So in about 2017, 2018, I started using Orlissa, which is an oral version pretty much of Lupron, but milder, in combination with birth control pills. Amazing. So I think like 7 years later now from this, I'm starting to see that there are new drugs coming out, and there are new classes of drugs that are actually looking to do a very mild antagonist of your own body's hormones to keep your estrogen levels low. So you add it in with a birth control pill, and there's a bunch of drugs that are on the market right now. There are also a bunch of drugs that are in the late stages of development that are showing the ability to help keep your hormones suppressed without the awful side effects of very strong suppression like Depo-Lupron. So to me, medical therapies are on the way, and it's super exciting. Okay, fine, I'll leave you one other one, and then we'll go. Just one of them. There's this other one called Gameto. So you guys should go look this company up because it's super exciting. Gameto, G-A-M-E-T-O, is not ready for prime time, but they're getting there. And this is a company that's actually figured out how to do something called in vitro maturation. So you take 3 days of fertility drugs, and then you have a retrieval. And then you mature the eggs in the laboratory. Well, everyone's saying, great, this is perfect for the PCOS patient because now you don't have to worry about overstimulating them and them getting sick. And I said, no, guys, you're thinking about the wrong population. This is the perfect drug for the endo patient because now you could maybe be aggressive for 3 days with medication, get a bunch of eggs, not worry about her estrogen going up, not worry about flaring her disease, and then do the final steps of growth in the laboratory. And if her belly is an inflammatory milieu or an inflammatory environment, potentially you can get those eggs out earlier and quicker without them being subjected to the deleterious effects of endometriosis. So those are my two.
Oh my God, so IVM is actually, I was part of the study for in vitro maturation, not by I was doing the retrieval for patient with IVM, which is maturing the egg, getting the egg at 9 to 11 millimeter. We only stimulate for 3 days, so you can use letrozole like Dr. Levine was trying to imply. You don't give high dose of medication. But the retrieval is not easy. You need to use a smaller needle. They have very immature eggs. Now we're getting those little nice 20 millimeter follicle. No way. You have to be very precise to aim right at those immature eggies. And we have to mature, and you have to use a sieve because when you get the eggs out, there are lots of conglomerates and dirts around it. It was part of an IRB study. It was, we were able to do the research. There were a couple of live births that came from the IVF. It worked really, really well. And thank you, Dr. Levin, for extrapolating to endometriosis patient. We were focused on PCOS patient. As you know, some of the PCOS patient will be having 60 eggs, which is like all or none phenomenon for some of the stimulation. But for patients who have cancer history, endometriosis, PCOS is one of the new technology come out, but the operator and the lab both have to be well trained because it's really hard to look for those small eggs in the lab. It's not those nice cumulus cells with mature eggies. So that's one therapy. And yes, I double down on Lupron and Orlissa. Those are all new treatment in town for endometriosis. But is there any new randomized control for Orlissa yet? Not yet. So that would be great also for endometriosis. But yeah, very interesting.
And what do you think about pre-embryo transfer suppression?
In the interest of time, yes. No, I mean, yeah, of course. I mean, anyone who has endo, your embryos are precious. And anything that we can do to just help you increase the odds, even if it's a singular percentage point. Everyone wants to do everything because the goal is to have a healthy baby. So I fully support suppression before a transfer.
Thank you so much. We could go on and on and on, and I could pick your brains forever. But thank you so, so much for imparting your thoughts and having a lovely discussion. I think it's time for lunch, and everybody's hungry. So thank you so much to Dr. Levine and Dr. Luke.
Thank you so much.
Thank you, guys.